It's always good to go second in a debate. So thank you, Ganesh sir, for this opportunity. So today I stand to argue for cardiorenal protection that should take precedence over glycemic control. So why this debate matters is basically CVD is the #1 cause of death in diabetes patients. So around 70% of people actually die from cardiovascular causes and not because of they had a high A1C. And diabetic kidney disease, of course, is the leading cause of end-stage renal diseases. And HbA1c alone is not enough. So HbA1c was the single most commonly pronounced term in the previous talk. So I'll analyze why that is not very important. So imagine HbA1c or glycemic control is a security guard guarding the front office. You are very happy. But the best way to picture cardiorenal risk is a thief going out the back door. So you are very happy that the security guard is guarding the front door, but he's going through the back. So we have to shift our focus from sugars to saving our organs and not just running behind HbA1c. Because let's face it, at the end of the day, you cannot say my patient died from a heart attack, but at least he had an A1c of 6.5. So the Himanshu actually spoke about the glycemic control trials, but he very conveniently skipped out ADVANCE and ACCORD. And he talked about only UKPDS, VCCT and VAD. So we'll just talk about analysis of these trials. So UKPDS, what they did, they took about 3,000 patients, newly detected diabetic patients, just newly detected, they took out 3,000 patients and they followed them up with intensive control. They had good results in terms of microvascular damage and there was some amount of reduction in myocardial infarction, but there was absolutely no mortality benefit. So there was absolutely no mortality benefit. The second trial, which he had highlighted, was DCCTAD, which included type 1 diabetes patients. So in the type 1 diabetes disease itself is a different mechanism as such, treatment strategies are different. You cannot use that data for our type 2 diabetes patients. So that is also out. And he conveniently talked about all these three, but ignored ADVANCE and ACCORD. So ADVANCE, what happened? There was some microvascular benefit, absolutely no macrovascular benefit. And ADVANCE is a trial which he had mentioned had taken a long duration, he had mentioned that the newer SGLT2 and GLP-1 analog trials were short duration. ADVANCE also had a long duration, but there was absolutely no mortality benefit. VAD, again, same thing, reduced HbA1c, no mortality benefit. So, and in fact in ACCORD, which we had skipped, tight control, there was an increased mortality rate by 22%. And this trial was actually stopped early. So that's why he probably ignored that. Now, talking about the cardiorenal protection trials, majority of the trials were short duration, but because why it was stopped early is because the steering committee thought that the benefits were much superior. That is why most of these trials were stopped early than the intended duration. And I don't want to go through the numbers. I just want to tell that EMPARAG and LEADER showed us that these molecules can save our heart. CREDENCE showed us that these things can save our kidneys. And DAPA-HF and DAPA-CKD actually showed us that these things can save lives because they included patients who are non-diabetics also. So these benefits are not dependent on any glucocentric approach, whatever the benefits these trials have shown. And as I had mentioned, DAPA-HF and DAPA-CKD had patients who did not have diabetes. So we know that it is not through the glucocentric mechanisms that these molecules act. And in terms of side effect profile, which he had highlighted, I agree canagliflozin had increased risk of amputation, but DAPA-HF, DAPA-CKD, there was no complications which were documented. And there were no issues associated with these newer SGLT2 molecules or GLP-1 analogs. In terms of GLP-1 analogs, he had shown us the retinopathy trials. In fact, we were part of FOCUS trial at Amrita, and the results will probably be out next year, end or so. Absolutely no association between semaglutide and retinopathy risk. So we are just waiting for that result. After that, you can use it very confidently. So this I just put because, again, the same thing. These molecules take care of your kidneys even if you are a diabetic or a non-diabetic, because our nephrology counterparts have started using these molecules in non-diabetic kidney disease because they know the benefit of these molecules even though we don't know it. So coming to HbA1c, as I had mentioned, that was the single most commonly used word in the previous talk. So HbA1c is supposed to be considered the gold standard and should always be prioritized. No. So why do we run behind HbA1c? Because of this. We know that higher A1c increased risk of retinopathy, nephropathy, neuropathy, macroalbuminuria. Yes. But diabetes has two components. We know that sustained chronic hyperglycemia, yes, but acute glucose fluctuations were not taken into account. We know that patients with even normal A1c, we can have acute glucose fluctuation. You can see here. This patient had a high A1C, calculated A1C, it's coming down to 7.5. Still he has acute glucose fluctuations with severe hypoglycemic episodes. This can drive protein glycation and oxidative stress, not just hyperglycemia. Now, this question, suppose your patient is asking you this question. Which is better, an HbA1c of 7.1 or 6.8? What would be your answer? Anybody? 6.8. So, traditional answer is 6.8. Now, the problem with that statement is, we do not understand the entirety of someone's blood glucose levels from HbA1c. Now, none of us would want to be the person on the right. You can see he has an A1C of 6.8, but if you see his CGM values, he has acute glucose fluctuation this side, that side. And this is what drives diabetes-related complications. So, I agree. Previously, we had an HbA1c, we didn't have anything else. Now, we do have newer markers to assess glycemic variability. So, if we are assessing glycemic variability with CGM, yes, I agree that that is something which you can do and you can, but we are not. Because as my previous speaker had highlighted that SGLT2 inhibitors and GLP-1 analogs are very expensive molecules, but so is CGM. So, until and unless you are using CGM, you cannot say that you are doing justice to the patient. So, we are supposed to target an area of low A1C and low variability and not just a low A1C, which we are not doing in our clinical practice. So, this is again time and range, as I had mentioned. So, ADVANCE, ACCORD, VAD, whatever he had presented, all these had different populations, different approaches, but the same conclusion. Intensive blood glucose level did not have CV benefits. And in fact, there were some increased mortality rates also in the ACCORD data. Now, suppose you cannot use these glycemic targets for all patients like we are doing. So, if you try to aggressively lower A1C in an 85-year-old female, that is like giving your grandmother a Lamborghini. There is absolutely no point, because the more you try to achieve more blood glucose level control, that you will be more prone to push the patient into hypoglycemia, advance the frailty, and increase the cognitive decline. So, in these sort of patients, actually a cardiorenal risk reduction approach is much safer. And tight glucose control in these patients is not actually medicine, it is extreme sports. So, that is why all these guidelines have started to change and make their priority not just A1C, they have started to individualize it. Previously, we didn't have this. So, time to effect, that is what matters. So, these cardiorenal benefits are seen very early. The legacy effect, it takes a lot of time. You cannot tell your 60 or 70-year-old patient that you have to wait for your hexosamine pathway, your polyol pathway, your advanced glycosylation end products pathway to take effect till you get benefits. Whereas you give them an SGLT2 inhibitor or a GLP-1 agonist, you will get benefits in 2 or 3 weeks. Whereas all these pathways will take so long. So anybody is familiar with the Northern Star? So previously, historically, sailors used to use it to find which is north. Nowadays, they don't need all that. They have advanced satellites in all these the boats. So this is the first standards of care which they had proposed in 1989, where they have just started to mention HbA1c as a target of 7%. Nowadays, we have all shifted. All the guidelines have started to mention cardiorenal risk reduction as the #1 phase. And modern guidelines, all the guidelines are shifting their focus, be it ADA, be it KDIGO, be it EASD, all these guidelines. So initially, HbA1c, lower the better was the dictum. Then what happened? They wanted lower HbA1c, but they wanted it without hypoglycemia and without weight gain, which was not possible. So now they have gone to an approach where cardiorenal risk reduction. I'll take a bit longer. I don't think he had taken 10 minutes. Anyways, so cardiorenal risk reduction, he had taken about 20 minutes. So cardiorenal risk reduction, so nowadays they've gone into a phase where you have to use agents with benefits. You should get some amount of glycemic control, but individualize the goals. Not just give insulin and OHAs to all your patients, maintain the A1C below 6.57 and push them into hypoglycemia. I'm not going to talk about all the mechanisms. Really, we don't know why SGLT2 inhibitors or GLP-1 analogs have benefits. Initially, we thought it was the glycosuria. No. Then we thought it was the BP benefits. No, because the Empareg, all these had only modest 1 to 2 millimeters mercury. That is not going to push your elderly patient into hypotension, the SGLT2 inhibitors. Then we thought it is the natriuresis. But all these mechanisms, we still don't know why SGLT2 inhibitors or GLP-1 analogs have benefits. So basically, the glucocentric approach is different. So you can compare your SGLT2 inhibitors and GLP-1 analogs to Swiss Army knives. They have multi-mechanistic effects rather than just taking care of just the glycemic control. And of course, the the residual cardiorenal risk. So the residual cardiorenal risk, if you look here, if you just go by an intensive glucose control, you are not taking care of the residual cardiorenal risk in all your patients. So if you have a patient with high ASCVD risk score, if you don't give these molecules, numbers needed to treat is just a number. Even if it is 40 patients to treat to get one patient's benefit, that is a huge number, because that once a patient develops cardiorenal risk, that patient is a burden to family as well as the society. The healthcare costs, the family costs, all these are huge numbers. For us now, when we are looking at the patient, we are just looking about the single cost of tablet. I'll come to the economic and public health perspective. So this is what Himanshu had highlighted. So the cost of the tablet. But if you look at this data, which was published in 2022, you can see clearly a patient with diabetes with heart failure, this is where he comes. A patient with kidney disease and diabetes, this is where he comes. Patient with ASCVD, here. Diabetes overall here, diabetes without cardiorenal risk here. So our UKPDS, what they did, they took about 3,000 these guys and followed them up and said that glycemic control is better. So in fact, our population somewhere comes around here. In fact, all our population patients who come to the OPD are somewhere in this segment. Again, if you look at the medication cost, we are looking at only the SGLT2 inhibitor or GLP-1 analog cost. Now, if the patient develops a heart failure or a kidney disease, imagine the other medications which he has. So if you look at the overall medication cost, it is here. If it's just a CVD, here, and without, here. So it is clear. It is not just about the cost of the medicine, it is how you convince the patient. So you cannot make the decision by yourself. You have to put it on a plate, give it to the patient, tell him that so and so are the benefits, so and so are what you will get. Whether you want it or not is up to you. To summarize, glycemic control, there is no mortality benefit, there is no heart failure risk reduction, there is some amount of renal protection, yes, microvascular complications, I did agree. Time to benefit, years. So you cannot convince your patient about pathways, you have to give them benefit as soon as they come to your OPD. Hypoglycemia risk, high, and in your frail elderly patients, you cannot just go by glycemic control, you have to give them benefits. Long-term cost effectiveness, there is strong evidence. So, he had put some questions in the end. I also want to ask some questions. So, does a perfect HbA1c guarantee heart or kidney protection? You can answer. I didn't have time to put those slides. So, does a perfect HbA1c guarantee heart or kidney protection? No. If a patient dies of heart failure and has I thought about these questions just now. So, if a patient dies of heart failure with an HbA1c of 6.5%, is that success? No. Thank you. So patients don't live on numbers or a lab report. They live to feel well. They want to avoid heart attacks, strokes. So to conclude, I'd rather not treat a patient by a report. I'd just give him a healthy heart and kidney. Organ protection is a clinical outcome. All this HbA1c is just a lab value. Thank you from the bottom of my heart and kidneys.
Yeah. Arjun, you have done a wonderful job. You have debated very well. You have given a beautiful rebuttal. But then, Himanshu also had a point. In our setting, of course, sugar control is one of the most important issue anyway. But all put together, it is like a car. You should have a best engine as well as you must have a beautiful car, beautiful tire without it being bust on the road in a very summer atmosphere. So I know that both of you must be really practicing both. But of course here you are fighting out. But that is all for good of our patients and health. But as Himanshu said and Dr. Arjun said, that UKPDS and our other legacy trials, whichever you are talking about, was done when these cardioprotective drugs were not at all available. So they didn't have any other choice but to just give the statistics of what it did. But when medicine is always evolving and it is a dynamic thing, when things come to protect ourselves, the most important thing is the health protection. Health is wealth. As Arjun said, if you have a good health, you can make any amount of wealth. But we have a beautiful control, as he said, 6.5 of glycated HB, and the patient is having a cardiorenal problem, dialysis, and going for heart transplantation, it's not really worth it. So, but then, as we say, your roof must be as strong as the basement as well as the foundation. So, the foundation is set by Dr. Himanshu, and the roof is set by Dr. Arjun. Both together, I am like Trump. Wherever there is a problem, I would like to go for a ceasefire, and I always want to claim that I am the man who did it. So, today we are going for a ceasefire where both of us will have to go for a moderate things between the two, and both are required as it is. And both of you have done a very wonderful job. And if any questions, please ask the questions only to the speakers.
If the doctor and the education materials can convince the patients to maintain euglycemic state, near euglycemic, not to the hypoglycemic status, with the available medicines for decades long, probably you can prevent the major organ macrovascular complications.
And when I spoke about glycemic targets, I meant individualized target, not a straight 6.5 for everyone. That is one thing. And glycemic target may include in future CGM and with Eversense and other CGMs which are long duration CGMs. We may have those targets also. So that if you, in the beginning only if you are controlling, then probably you are going to.
No, that's why I said it's always good to go second.
Anyway, together we'll have to protect the whole human body. It is not only just the heart and the lung. His emotional aspect is also very important. And at the end of the day, when the cost is too much, and now with all the rising prices of petrol, diesel, and we are expecting the petrol, diesel, and all those things are going to go up thanks to Trump. And with all that vegetable prices going up, fish prices, and chicken, mutton, all going up. And we are going to add GLP, GIP, and triple cretins, and so many things we are going to add. The patient will finally feel it is worth not living itself. So that being the case, I think we'll have to convince, console, and manage all the patient without much trouble, but with a lot of good effect. Thank you so much.